instead we come in and say, oh, there's this little piece of it here. I don't like how the hospital's doing this, regulation. Oh, I don't like how the doctor does that, another regulation. I don't like how this is being done, documentation requirement. I don't like how this is done, we're gonna bring insurance in here to regulate that. You know what I mean? So it's all these little piecemeal fixes, right?
Yeah.
But so it's like saying, I've got a house, the house of healthcare has a cracked foundation and a collapsing roof, right? And really needs to be bulldozed and rebuilt, right?
Right.
But what we instead keep doing is we repaint the door 3 or 4 or 5 times, right? And we put some duct tape over the hole in the window, right? And we're like, let's just keep this thing going because it's just we can't get rid of this thing because if we do, there's too much disruption.
Welcome back to Dear Healthcare, It's You. We are back with Dear Healthcare, It's You. I'm Joe Hanlon and this is Dr. Elisha Yaghmai. This is our last podcast episode. How do you feel about ending this season? Season
Good.
1? Good. We've talked about a lot of heavy stuff so far.
Yeah.
We've been going through Elisha's journey in medical school, in his residency, in his early career and beyond, talking about the healthcare business that he built from the ground up along with some partners and then going it solo and then back with some partners. And a part of that was telemed, part of that was a physical clinic here in Wichita, Kansas, Free State Healthcare Clinic. And that is now closing. And that's new. Mm-hmm. That's a new piece of the puzzle in the plot. So was that a recent decision or have you known that would happen for a while?
No, I mean, the decision itself was fairly recent. The build-up took a long time.
Yeah.
And to be clear, the rural side of what we do is not closing. That's continuing. All the stuff we do in that area is going. It's the clinic that's closing specifically, the primary care clinic.
Right. What was it that brought you to that conclusion to close that?
The short description is I tend to view things from at least medium term to long term in terms of how I think it will play out. Mm-hmm. And so when I looked at it from a long-term perspective, I was not convinced that continuing the work that we were doing in the clinic, as helpful as it was for many people, was going to accomplish what I had wanted it to accomplish. That may be the way to describe it. Like it was able to help patients. It was able to, it was able to do the things that you would want a clinic to do. If you're taking a clinic as sort of a business concept or as a service delivery module, it was doing those things. But it was not, in my opinion, going to get us to the change that we need on a national basis, to deliver better healthcare.
Were you going into it hoping that it would make a broader change than just in the communities that you were working?
Yeah, I think the impetus for it was, and we talked before, right? I mean, the original reason we started a clinic was because the insurance companies forced us to have a physical clinic to be able to build them to do virtual care.
Yeah.
So it was sort of
hoop that you were jumping
nonsensical
through.
Hoop, right? But very quickly it evolved to saying, well, if we're going to have to do this, then we might as well try to solve access to care in the urban environment. Mm-hmm. And from my perspective, access to care in an urban environment is financial. Yeah. So the rural folks, have a problem getting to any doctor.
Right. It's just not there.
Yeah, they're just not there, right?
Yeah.
But urban people, there's doctors all over the place in most cases. They just can't afford to see any of them.
Right.
So this is the problem. And so my initial thought, again, very much like rural, I started with a very simple concept, which was, okay, well, people can't afford to see the doctor. Mm-hmm. So why don't we use technology to kind of create a system that would enable us to see the doctor? And to start off doing that, we borrowed a lot of things from what's called concierge medicine. Actually, we talked to them. They were very open about the types of techniques they used to try to help save their patients money.
Other places that were doing that model.
Were doing concierge type medicine, subscription medicine, but you pay some amount of monthly fee, right?
Yeah.
And so we borrowed things in terms of how to create affordable labs and affordable imaging and things like that. Well, I say affordable, more affordable,
right?
Affordable than they would be with insurance. Mm-hmm. So we borrowed concepts that they had developed in terms of how to create more affordable labs and imaging and things like that. Mm-hmm. Here again, not as affordable as they could possibly be, but more affordable than they would be using insurance. Right? Yeah. So instead of an MRI for $5,000, you could get an MRI for $500. Right.
Gotcha.
Prices like that. Right. So that was, so we utilized all those things, and we, pretty quickly figured out, okay, we would need to offer even lower price points to really be accessible to people. Because what we found when we initially started, we more or less copied the same concepts that were being used by others.
Yeah.
What we found is that the population that we were getting were actually people that were actually pretty well off in many cases. Like they were essentially coming in and saying, I want to have a doctor on kind of speed dial.
Oh,
and I'm
okay.
willing to pay a fee to do that. And then I'm going to also maintain health insurance, right?
So it was more of a dedicated service rather than an affordable service.
Exactly, right.
Okay.
It was more about that, right? And so, and we can talk about concierge medicine and the different issues with it, right? At this point, I'm not convinced it's the answer, but there's a whole debate and discussion you can have about that and data.
Sure.
We can skip that. Long story short is we cut everything down. So our subscription was $5 a month, right? If you came into the office to see us, it was $25. If you saw us online, it was $1 a minute, right?
Yeah.
It was these kinds of things. You could see a specialist for $75, right? So prices that were substantially lower than that. And we had control over that, and we did a lot of back-end work to make those prices sustainable in some way. So we did all that, but there were kind of three things that we began to realize over time. So the first problem was that the people that really needed this, right? These are often people that they're working, they can't afford health insurance, right? And they don't make enough money where it's like, hey, you know what I can do? I can drop $500 to see the doctor, or $400, right, to go in. That's just not that's a non-starter for them. So they needed an affordable way to access care. And so the problem is that we're doing this.
Yeah.
But oftentimes they're sitting on problems and conditions that they'd had sometimes for years that have gone undiagnosed, right? Or sometimes it was a new problem, but they had waited 8 months to get evaluated for it because they were trying to save up the money.
Yeah.
And then all of a sudden they find, oh my goodness, I can actually see a doctor for $25, right? I'm going to do that, right?
Yeah.
This kind of thing was going on. So they would come in and we would find their cancer, or we would find their heart disease, or whatever it was. And then we would have to refer them back out, right, into the general healthcare system, which did exactly what it always does, right? We couldn't control the price. So to go see the cardiologist was way too much money. To go get a surgery was a ridiculous amount of money, right? So in a sense, it was that sort of frustration of saying, well, okay, I have now identified what has been causing you problems.
Right, but we can't do anything about it.
There's nothing I can do about it, right? You have to have this money. And if you don't have this money, then I don't have any means to help you.
So now you're just aware of how sick you are.
Exactly. You have a name for the problem, right? But I can't help you, or the med that you need is, $50,000 a month, or just some ridiculous thing, right? And in our country, we've decided that that's the way it should be, right? If you're not wealthy enough to afford that, then you just get to go die in a corner somewhere, right? This is kind of how it is. And so this is what was happening, right? So we had that frustration, though, of the initial hope of we can help you figure this out. And then doing that, running into the frustration of now I need to fix it and I can't. So while we were doing that on the cash pay side, we also had insurance patients coming in, because at one point we looked at it and said, you know what, we want to be able to help people, particularly people with public insurance, so Medicare and Medicaid, right? These are people also who are usually on limited income, but they qualify in some way or another. And we had the same problem. So it'd be, a Medicaid patient would come in and we'd figure something out, and then we'd try to refer them to the necessary specialist to do the next diagnostic step or to treat, and they wouldn't take them. Right, because they're like, I don't take Medicaid. Oh. Medicaid was class. Medicare people would generally take, but Medicaid, no, they often won't, right? And they won't because they feel Medicaid doesn't pay enough, right? So they wouldn't take them. So here again, we're like, well, there's only one option in town, and that option doesn't take Medicaid. So you're kind of up against it. Like I can't help you. There's nothing I can do because I don't have that. I don't have that device, right? I don't have that tool, or I don't have the training necessary to do this properly. So I can't do this piece of it. I can take you up to a certain extent. I cannot take you further. Right. And you are just out of luck because you have CanCare, and nobody wants to take CanCare because it doesn't pay. Right? So, that ongoing frustration, right? So that's one.
You seem like someone who thinks many steps ahead. And the problems that you were just describing, not on the insurance side, but on the other side in terms of not being able to control the rest of the realm of healthcare besides your realm. I'm guessing that wasn't news to you, right?
Correct. Yeah, that's right.
You had anticipated those issues. Had you thought that it would be different than it did go?
Yes, I thought we could begin to build internal capacity to meet those needs.
Okay.
But that didn't happen with the speed with which it needed. Like, essentially, I thought we could get there by chopping all the wood ourselves. So here, this goes back to sort of the nature of American business, right?
Yeah.
American business, the old school American business was you start this business and you try to build it up over time, and it takes many years, and maybe you get some investment. And American business in this era is you go out, you come up with an idea, you go out and try to find a bunch of investors to give you a whole bunch of money, right? So that you can almost drop the thing fully formed right into the marketplace. I had thought we could do this kind of old school style, right? Which was, okay, we'll start off with primary care, right? And then eventually we'll hire a surgeon,
Okay.
right? For example. And then maybe we'll hire a cardiologist, or you know what I mean? Like this kind of thing. We'll slowly kind of get there. And the problem was that it's not necessarily that that wouldn't have worked. It's just going to take a long time to get there, right? And and so my realization was this is going to take a really long time. And there's just so many pieces of this. That was the one thing, right? So there's so many more broken pieces. Like it's not just a matter of having a surgeon, right?
Yeah.
You need so many other things that back that for it to work, right? That to do this, you have to come back. You have to hit it basically from the beginning with a lot more resources to be able to offer a much more comprehensive, essentially, ecosystem into which people could enter that meets all the different needs. And we were not going to get there seeing one patient at a time, right? From a primary care clinic in Wichita, Kansas.
Do you think that it would have gone differently, not only if you had had more capital at the beginning, but I mean, you not wasted away, but in a way, like that has a negative connotation. You were doing so much though on your own for so many years and financially keeping everything afloat in a way that obviously wasn't sustainable. That even when you got past that point and were getting insurance and stuff, I mean, you had so much against you for a long haul. I mean, at the start of this, if that hadn't have been the case and you had been able to start getting insurance right away and have your partner stay in and stuff, do you feel like it's something that you would still believe in trying to flesh out, or do you think you'd still be at the same place?
Yes, I think we could have made it had the operating environment been different to start.
Yeah.
It's not a guarantee. There was at least a better chance. That's probably how I would describe it.
I guess maybe a better question is if you could push a button and go back and have that knowledge that you could start with insurance working and thus be able to keep more people on board and not have to do so much yourself and have a different chance at it, is it still a thing that you would put energy into, or would you still want to go a different direction?
At this point, I would want to... actually, it's a tough question. I mean, if we had enough capital, I probably would be willing to take a second run at it. But we would really need a substantial amount because of all the things you need to create to make it work.
You're basically needing, it sounds like, with your thought on it of like how to bolster your practice that you had with these different components. It's reinventing the wheel in a way in the healthcare scene. You're having to build up a whole system. You need
a competing healthcare system effectively, right? That is predicated around affordability and access. And the difficulty, we'll take it a step further than that. The difficulty beyond that is, where do you get the capital to do that from? You get that from people that have money that ultimately want a return on their investment.
I was going to say, they want an investment.
They want an investment, right? Exactly. You're not building in that sense. You're not building from their perspective. You're not building a public service. Right. You're building a thing that gives them a return.
Right.
Relatively few people that do that are thinking about the return is a better country for my grandchildren, right? The return is, I give you $50 million and I want 65 back, right? It's like that, right?
Yeah.
And so that tension, I think, is a really serious one, actually, in healthcare. And I am not at this point convinced that we can get there through that means. I'm not convinced at this point that healthcare, at least most manifestations of healthcare, really should be for profit.
Right.
I'm not sure it works. I think...
Which that's a change that you hadn't even thought about.
I hadn't thought about it. Yeah, I really hadn't thought about it. But over time, as I've just been exposed to it, I've seen all the different sort of moral hazard that arises out of a for-profit arrangement. I'm not fully convinced. Like I can understand how people can make money from it. I get that. And I can even understand what the value of it may be. And in America, talking about anything not being for profit is like, sacrilegious, right? But healthcare it's a different thing. Like you can't have people need health in a way that they don't need almost anything else in their life, right? In other words, like if you want to buy a certain cereal and you can't afford it, you can find other food, right? But you cannot get a second health.
Yeah.
There's not a cheaper health, that you can have, right? Yeah. And so that's the problem. And so here again, what did we see in the population we were treating? cheaper health, right?
Right.
Oh, I'm sorry. You're too poor to have your diabetes controlled. You could just lose the feeling in your feet. Oh, you can't work anymore. Well,
Right.
now you're a drain on society. Why aren't you paying taxes, right?
Right.
Well, they can't pay taxes because their feet are rotting off because
Yeah.
they can't afford your stinking expensive diabetic medications, right? You know what I
Right.
mean? Whereas if you had affordable diabetic meds
Yeah.
that they could purchase and take,
Yeah.
then they would keep their feet.
Right.
And then they could continue to work and contribute to the tax. Do you know what I mean, right? So it's this idea of, in a sense, it's like the military. It's almost like if you have the military for profit,
Right.
you're going to have some problems very quickly,
Well,
right?
I was thinking like fire. It's like
It is.
Healthcare is a public service,
is.
and it would be
Yep.
asinine if
Yes.
our fire stations were
Yes.
for profit.
Yes.
And in the same way,
It's that's exactly it, right? If you would have to pay them, like your house burns because you can't pay, which, there were societies that did that, right? If you didn't pay them, your house burned to the ground, right? But I'm
Right.
like, the reason we don't have that is because you need houses that don't burn down for
Yeah.
people to be able to contribute meaningfully to your society. Healthcare really falls pretty squarely into that, and increasingly so, right? And that, I would say, go
is
ahead.
that because as you're saying that, I'm like,
Yeah.
okay, and so fire, for instance, or the military funded by our government, and healthcare we fund by our government through insurance.
Well,
like
we don't. We fund it through employers mostly, right?
Well, true, but
Yeah.
I mean, like, it's not direct to the thing that we need, though. It's to the thing that pays for the thing
Yes.
that we need. Like, it's not
Also true. Yeah.
it's not we don't have that direct line of funding in that same way.
Yep.
We've built this alternate way so that it's multiple steps where people
Yep.
can make money off of it still.
Yeah, each step there's someone
Yeah.
making money off of it. Yeah, that's exactly the deal.
And so that's how our system is built. So to have a truly nonprofit system,
Yep.
You're combating every aspect of
Right.
that.
Yes. And so fundamental to that, right? That thought process
Yeah.
that you've outlined, right, was the realization of, okay, we need a revolution. We need we can't incrementally improve this. It's not this, you got this big knot, right? Like Trump famously said, right, healthcare is complicated, right? And people made fun of him, but I was like, that's,
Yeah.
that's pretty much accurate,
Yeah.
right? But it's not complicated in the way that theoretical physics is complicated, right? Or
Right.
calculus is complicated. Like
Yeah.
they're inherently just tricky and detailed, right?
Yeah.
It's complicated for bad reasons.
Like, we've made it.
We've made it complicated in the worst sort of human way possible, which is everyone comes in and bolts on their piece
Yeah.
to this monstrosity.
Yeah.
But at no time has anyone, the society, our representatives, nobody has sat down and said, what do we want from this thing? What do we want it to do for our country, right? And how can we arrange it so that it produces the outcome that we desire?
Yeah.
Instead, we come in and say, oh, there's this little piece of it here. I don't like how the hospital's doing this regulation. Oh, I don't like how the doctor does that, another regulation. I don't like how this is being done, documentation requirement. I don't like how this is done, we're going to bring insurance in here to regulate that. You know what I mean? So it's all these little piecemeal fixes, right?
Yeah.
But it's like saying, I've got a house. The house of healthcare has a cracked foundation and a collapsing roof, right? And really needs to be bulldozed and rebuilt, right?
Right.
But what we instead keep doing is we repaint the door 3 or 4 or 5 times, right?
Right.
And we put some duct tape over the hole in the window, right? And we're like, let's just keep this thing going because it's just we can't get rid of this thing because if we do, there's too much disruption, right? There's too much
Right.
disruption. But there's a point in human society and in human just evolution where things get to the point where they have to be swept away and replaced.
Yeah.
Our healthcare system is on that list. When and where and how exactly it happens, I don't know. But it's one of those things that has gotten too big and too tangled and too bureaucratic for its own good.
Yeah.
And there needs to be a time in which there is a real conversation about what do we want, who do we want it for, how do we want them to access it, what outcome should this system produce,
Right.
and have we optimized it to produce that? Inarguable right now that none of that's gone on.
Which is that, like, I'm curious in terms of your thoughts on this for the difference of demographics, like for the wealthy classes of America. Does it seem like they're satisfied with the healthcare that
They're
they
satisfied. If they are satisfied, it's because they don't understand what's going on, right?
Yeah.
So one of the things that we've talked about here periodically, right, all these kind of horror stories, right,
Yeah.
in care. So you have different layers of people, right? We got people that are wealthy. They can afford health insurance. They've got solid employment, or whatever it is, right? They can access care.
Yeah.
What they don't understand is how much garbage care they're actually getting, how many near misses there have been, how many screw ups there have been in their care, how many misdiagnoses, how many inappropriate prescriptions, all these other things are going on. So they're not actually getting the best quality care. And again, every time this comes up, people always try to nail it down to like one, oh, that's a bad actor.
Right.
That's a dumb doctor. No. Almost all the time, the system is the problem. When you dig into it, and that's something hopefully we'll do in future seasons of this, the system is the problem. The behavior is a system issue. It's not just one bad apple stuff, right?
Right.
So they don't realize, you can access it, but what you don't understand is that specialty you went to see is kind of terrible. It's kind of terrible, and the other doctors know it, but nobody else does. You certainly don't. And so when they send you off on whatever wild goose chase they've sent you on, it's because they're not good and it's not being detected.
Right.
Again, why is it not being detected? System issue, right?
Right.
So, they're making a certain, that surgeon you went to see that recommended that therapy, there's a reason he recommended that therapy, but it wasn't in your best interest. I can tell you that, right? Again, system is dictating certain types of behaviors and certain choices that are being made. So you, the wealthy person, assume you've got access to everybody, all the best of everything. You have no idea what you're actually encountering when you go in. Go down a level to the people that are not wealthy enough to do that, or where consuming healthcare is a serious decision, right?
Yeah.
Should I, I appear to be bleeding to death. But can I afford the ER right now? Maybe if I just put a tourniquet on and maybe I can not bleed to death enough, right?
Right.
So that I don't go bankrupt. So you have that, right? And then we have people one tier below that, socioeconomically, right? It's just not even an option. It's just not a thing. So it doesn't matter what's going on, right? They can't, they have no option. They can't afford a doctor. They can't, even if they went to the doctor, they can't afford the medications, right?
Right.
If they went to the doctor, they can't afford the tests that need to be done, right?
Yeah.
I can tell you how many times we had things where you need a CAT scan. They can't afford the $200 CAT scan. They can't afford it, right? So we can't move the care forward because it's not an option for them to afford. And there are zero people trying to make that CAT scan affordable for those people, even though I am very sure there's a way to do it.
Yeah.
No one's trying to do it. Nobody cares, right?
Yeah.
And then because they're in pain or they're disabled by whatever the problem is, they can, over time, their ability to so-called contribute to society is eroding.
Right.
Which
ultimately,
and we just write that off.
So then they stop working, they're disabled, they don't have as much mobility.
That's right.
They're not able to eat as well, they're not able to exercise. There's so many different things. As you were talking, that's where I'm like, I think that the wealthy classes, I may not hear as much dissent about healthcare from that realm, partly because they don't have some of the other pain points in our systems, in our social systems and structures in terms of what causes us to be unhealthy and need healthcare in the first place. It's like, they're able to afford better food.
Right.
They know about nutrition, period. Like there's these different hurdles that classes that are under that level don't have even that preliminary access to, which puts them in the seat of needing more.
Needing additional care. Yes.
Yeah. So it's not just that it's not working for some people. It's really not working for anybody.
It's not working for anybody.
Whether they notice it or not.
And to that point that you raised, that was a secondary issue, right? Which was our people. So when you work in primary care, you work down at the grassroots level. You see people at the front line of everything. Our people as a country appear to be getting sicker, worse, more unhealthy in every possible way, right? So significant percentage of our country is morbidly obese. Yeah. Huge part of the reason. It's not just, so one is the food and what's in it and the types of foods that are marketed and pushed, right? But it's also, people use food as a coping mechanism for all the other economic and social stressors they have in their life, right? So all of these things are happening. And again, who does, let's just take morbid obesity. Morbid obesity, right, leads to all kinds of other health problems, like high blood pressure, diabetes, right? You name it. Almost every health problem you can have is made worse, right? By carrying around excess weight. Yeah. A lot of people that are carrying around excess weight have economic and or psychological drivers for why they're, sure, you can talk about, you should eat some fish and throw in a vegetable. I can't afford that. Right? Can't afford it. Yeah. So that's not happening. I'm eating at McDonald's, right? Yeah. This is what's going on.
Yeah, so I saw I saw a TikTok the other day. It was someone saying like, how often do you eat fruit? And they're like, every day. And they're like, every day? She's like, yeah, you're supposed to eat fruit every day. And he's like, no, like once a week. Like, it's like, and then it comes down to, it's like, who can afford fruit every day?
That's the issue.
Like that's a piece of it
Yes.
for sure. Yeah.
It is. So with that context, the same people that are being afflicted by the sort of economic and social structures that are producing unhealthiness, right, or at least make people tend to become unhealthy, have the problem of once they get to that point of becoming formally sick,
Yeah.
what option they have? None, right?
Right.
Take another one. Mental health is a classic example, right? So through all ages, everyone we see, mental health has gotten worse across this country in the last, just in the time I've been practicing. Like it's just gotten worse and worse and worse. The young people now are
Like what stats or things are you seeing that make you say that? Just colloquial,
I mean,
them
the most obvious one is just suicide.
Yeah.
The rate of suicide in young people has shot up in the last 10 years, right? But even for those that don't commit suicide, they can't tell you the number of kids we see now. They're teenagers, right? Coming in with serious problems with depression and anxiety, right? Really serious, that are really affecting their life. This was not a common thing 15, 20 years ago. It was not a common thing. For that age group, it was not. I mean, it was something you saw intermittently, right? We would occasionally see a suicidal teen, right? Now it's like all the time, right? You'd occasionally see a child that needed some kind of psychiatric help. Now it's a lot of the kids, right, that we have. And then those psychological problems are manifesting in the form of various other maladaptive behaviors, be it drugs, alcohol, overeating, whatever else it is, right, that are producing other additional physical problems. And then you say, oh, okay, well, you know what you need? You need therapy. You need to see a psychiatrist. Well, guess what? A psychiatrist is $250 an hour.
Right.
Right? You know, the therapist is some ungodly amount of money. That 19-year-old doesn't have that money. Right? So how are they going to actually be helped with their problem? The answer is they're not. Right? They're not. How are they going to afford to take the meds that you prescribe for them? How are they going to manage the side effects for that? Who knows, right?
Yeah.
No one seems to know or care.
For those meds, I mean, from people that I know that have used them, it's like you have a time that like you're figuring it out.
Yes,
like, and that
that's
takes
right.
many, it's not like one visit to a psychiatrist.
Yes.
It's like
That's right.
many until you get your dosage right.
That's correct. And it has to be monitored, and you got to monitor for side effects, and sometimes you have to make adjustments, right? There's all these things, right? So there's all these touches you're going to have in the system. But then fundamental to that or below that, you ask, what is going on, right? I mean, what is going on that this is even necessary in the first place? But let's say we don't know. And there's lots of theories, right? In terms of why we won't get into all that. It's just, let's just say it's happening, right?
Yeah.
Okay, cool, it's happening. What structure do we have to help with that? It's a terrible one.
Right.
It's a terrible one.
The mental health portion of healthcare, at least on just my layman's side of things, seems very separated from the rest of healthcare too. In a lot of, I mean, aside from a psychiatrist, like in terms of therapists who are more accessible price point wise sometimes. And some people need to see both. For meds on one side and then therapy on the other. You know, it's like, it's almost two different sectors, and like, you might not even find a therapist that's available that you like, that you is on your insurance at all, like even if you have insurance.
Yes.
So it's completely segregated. It's treated as if it's completely segregated.
Right.
And it's obviously, we know so much more now, but we're so integrated as human beings.
Right.
Like,
but it is treated as separate. Yes, it is. And yet it has the same fundamental problems, right? Which is it's not affordable. It's not readily accessible, right? And here again, so we can say, well, the psychiatrist, cost too much money. Okay. You have to think through something like, what are you asking your psychiatrist to do? Okay. They have to have an hour-long meeting with you to talk about whatever. Just use this as an example. Then they got to write 30 more minutes about what all went on in their hour-long conversation with you. What does that mean? In an 8-hour day, right, they're spending a significant chunk of their day not seeing any patients.
right.
So what does that mean in terms of how much they need to charge to make a competitive rate, right? And you could say, well, the rate is too high. Okay, rate's too high. The problem is that you don't want just anybody going into the field, right? You have to have some kind of standards to pass, right, to get into the field, right, given what it is. Not everybody is going to be able to do that in the first place, right? So you could try to solve it by lowering those standards, right? But then you're going to have some decrement in quality at some point, right? Which, you know what I mean? Like the point is not that, I have this magical solution that's going to solve all this, right? The point to understand is it's not just greed.
Right.
That's driving everything. It's the way this whole thing has been constructed, which forces certain behavior, which in turn forces additional behavior downstream. But the end solution is, man, we're in a bad situation, right? This situation is not going to work, right? So you got rising mental health needs. You're going to suddenly produce another 100,000 psychiatrists? No, that's not happening, right? So you need to come up with a different way for that. Like, you see what I'm saying? We need to ask, what do we want? We want better mental health. How are we going to get there?
Yeah.
It's not by continuing more of the same.
Right.
Right? It's not that we know this system is breaking down and failing. It's not going to work. Now, we talked about mental health, but the same is true for diabetes and high blood pressure and heart disease and emphysema and, just
every specialist you have to
see. Everything is like this. Even our primary care, right? We say, what does our primary care have to do? Well, because their reimbursements keep going down, right? And again, we talk about reimbursement. Doctors always focus on reimbursement. It's not the reimbursement amount. It's, again, what are you asking of the doctor, right? This happened to me doing insurance. So if I'm seeing a certain number of patients a day, right? I end up in the same situation that I was describing earlier in the hospital, right? My choice again is kill myself or kill my patient. So I see you and I order some tests, right? Okay. So the first thing is, did those tests, I have to track all, because there's no unified system, right? Send you somewhere to get some tests. Did you ever go? If you got those tests, were the proper tests done?
Right.
If the tests were done, did I get the result back?
Yeah.
Right? Did I get it back in a timely manner? Right? You can see, okay, then I saw it, and now we need to do some more things, right? Now does that information communicated to you?
Right.
If so, did you follow through on it? Right? If so, did that actually work? Right?
And that's all assuming, as for some of your former examples of that it was read right along the way.
That's right. That's assuming that if we did a CT scan, it was even interpreted properly, right? I mean, the lab was done and there was no error. That's assuming the technical stuff all works flawlessly, which is not true.
Right.
Which is not true, right? So I have to do this, and now I have to do this for every single patient. What does that take? Because it's all a manual. They're all duct tape systems, right? They don't all talk to each other. You don't have a unified medical record I can access, right? It's just your stuff is here and 14 other places. It's all split up. So I and my staff have to invest an enormous amount of time just bird dogging stuff to find out. We made a referral. Did you ever get there? Did they do the scope?
Yeah.
If so, what did they find? Right? All of this stuff is going on, so it's time. And so the problem again is my time is being used on things that you don't need my time for.
Right.
Right? It's doing manual review and track down of information. You don't need an MD for that.
Right.
You need a computer system. That's actually what you need. You need a unified software system for that.
Right.
But we don't do that. So instead what we do is we go to our primary care doctor and we say, you need to, keep cutting the reimbursements there from Medicare, so we need you to see 35 people a day, right? And then the patients are like, why does my doctor only spend 5 minutes with me?
Right.
Because they have to see 35 people a day. And then what you don't see is that after they finish the 35, they have to write a note about all 35 of those encounters, right?
Right.
So they go home and they spend many more hours writing, if they're doing their job properly, many more hours writing about it. Or their alternative choice is cut a bunch of corners, slash this down to the absolute bare minimum and just slap enough text on the thing to get paid, right? Which is not the same as saying, I did a good job medically, right? Do that, right? And just keep it moving, right? Yeah. So, we'll describe them, of course, as very efficient, right? Because they crank through and they crank out that work, and hospitals and other clinics love that, right?
Right.
But the question is, are they doing a good job medically? I mean, there are a few people that can balance it, but for a lot of people, no. There's a contradiction between these things, right? Detail work is not usually fast.
Right.
Doubly so when you're working with systems that impede your ability to access the information that you need in the first place, right?
Yeah.
So a lot of your work time is spent manually tracking down junk.
Right.
So this again, right, puts you back in an untenable situation. You have to grind yourself to dust, or you have to cut corners for your patients, or you have to do the other common complaint, right? My primary care doctor just always refers me out. They don't even listen to me. They just refer me out, right? Why are they doing that? Time.
Yeah.
Time. They don't have time to pursue if they order that 18 labs need to be done, they got to follow that up.
Right.
Well, guess what? They don't want to follow that up because they got 37 other people that they need to do this on today.
Right.
Not even for this week, for today, right? They don't have time for it. If they tried to do this is the thing, we tried to do this because we had cash pay patients and other people, right?
Yeah.
What you end up with is every day you walk into a stack of paper, no joke, it's about that high, right? That you got to go through. And then as you're going through it, more is coming in, right? And then more is coming in, and then more is coming in, right? So you are being punished for trying to do the care the way it actually should be done in the view of most of the physicians that would try to deliver that, right?
Right.
All of it is a bad system.
Yeah.
It's bad system, stacked on bad system, stacked on bad system. And it perpetuates because right now there are the most powerful parties in healthcare have won this game. They're all benefiting in their own way. But the users of the system, the people that deliver service in it and the people that receive service from it are for the most part losing over and over and over and over again. no one cares in some
Right.
fundamental way. Right? No change is forthcoming to fix a lot of these very fixable problems.
Yeah. So do you feel like you're just throwing in the towel? It's been too much of this losing battle of you finally feeling like you're putting up the white flag and being like, I got to try a different attack.
Yes, yeah. It's not giving up on the things that need to be solved.
Yeah.
It is changing approach.
Okay.
This is actually one of the attempts at changing approach, because maybe I'm
This
too
podcast.
this podcast. I may be too optimistic, but my operating theory is that many people in this country, though they don't love the healthcare system and think it's too expensive, do not really understand how it works, why it works the way it does, and how they are being harmed by it, or will be harmed by it in the future if they have not already been so.
Yeah.
And so I would like to disseminate that knowledge, help people understand what is actually going on inside of it, in the hopes that plus explanations of why it happens, not just what happens, but why it happens, may provoke the kind of thinking needed to create the revolution that we need.
Yeah.
Because in the end, I'm at this point pretty convinced we need a revolution of sorts.
Yeah. I mean, you've continued to use the word systemic, and I think that's the appropriate phrase here. That's the appropriate definition of what we're up against in healthcare. Is each of the examples you give, you're very clear along the way of saying, this isn't just one-off. Like, this has happened here and here and here, and I can give you 100 examples that all point to the same systemic problem. And so, I mean, we see that throughout our society in a lot of places right now. I think that we're finding, it's like, if you use that analogy of the house that you talked about, there are many of our systems that are feeling like we're just holding them up.
Yes.
For no reason, and while it's crumbling.
Yes.
And maybe we're being injured while it crumbles.
They're being sustained for their own sake, right? They're being sustained for the sake of their existence rather than for the function that they were allegedly created to fulfill. In the case of the healthcare system, nothing was ever created. It just sort of sprang up over time.
Right.
Like weeds, and it was never organized into anything. It's just been sort of it's been retrofitted, basically, right? Rather than created with an intention.
It's like a patchwork system that got institutionalized.
That's correct. Yeah. And now we just within the system, the people inside the system basically look at it and say, well, it's dysfunctional, but you can't do anything about it, right? It just is how it is, right? And that's maybe the most important thing out of this, right? For people to take. It's not gravity. It's not gravity. Humans created this system. It can be unmade.
Yeah.
It can be completely thrown out and revised. We have the power to do it. We actually do, but we need to unite behind understanding first what we want, and then get our act together and start organizing to create the change we want to see. So
do you feel like that starts with awareness is what
I think
we're working on here
I think
now?
with a lot of issues, I mean, think about the things that have changed positively in the society, right? Most of the time it started just first with awareness in the face of a lot of skepticism, right? Oh no, everything is fine, everything works, it's all proper, right? It wasn't.
Right.
But we need people to understand that.
Yeah.
Right? And then, because the thing is, it's not like I have every perfect idea, right? I make no claim to that, right? But what I can tell you about are the problems. And to some degree, I can tell you about why the problems exist.
Yeah.
Now what we need is the help of a lot of other people to look at the problem and say, oh, you know what? I have an idea, right? And I can tell you just in the microcosm, to give you an example, like we talked, about how we got more cost-effective telemedicine technology, right? Yeah. That was by cobbling together good ideas that people had in other areas, right, to create a thing that solved the problem.
I mean, that stethoscope that you guys first used was just already on the market, not being utilized in this scenario, but perfect for it.
It was, right? This was the kind of thing, right, where it was created for a different purpose, but it happened to work, right? Yeah. And there were other tools that really were the same, right? Each thing was created, like the creator was not necessarily thinking about this specific application of it.
Right.
Right, but they had a good idea, they created a thing, and you could pull it together. And there have been other areas, even when we were looking at things like the clinic or other areas, where some of our learning in terms of how to create a certain logistical or practical outcome was gained by looking at other industries.
Yeah.
We'd run into things where there wasn't a precedent for it in healthcare. It wasn't done, right? Or no one had really tried to do it. So we just looked at other industries. In the other industry, they solved this problem 35 years ago. So we would just say, well, let's just learn what they do and copy the tools, right? And bring it over here to solve the problem. So I think this is that kind of situation where we need the insight and ideas from many different people in many different fields. It may have nothing to do with healthcare.
Right.
But all that starts with understanding what is wrong, why it's wrong, and then what do we actually want? What would be better?
Yeah.
And then we can solve the how do we get from where we are now to what would be better.
Yeah. And I think even before the, what is wrong, like helping everybody understand how they're affected by this is a major part of it. Because like you said, whether they have been yet or not, or I mean, there's been things that I've thought about as you've given different examples where I was just like, oh, that's probably what went on in this specific scenario that I was privy to, that we had no idea that that's what was happening in the back end. And they just, keep us at X hospital for instead of transferring or things like that. But, that they may have already been affected by these issues, I guess I'm saying, without even knowing it.
The patients, I'll say this, the patients that I have seen killed or otherwise harmed in the healthcare system have come from all backgrounds and all walks of life. It's very democratic in that sense, right?
Wow.
Anybody can be harmed. Anybody can be harmed at any time, in any place, and a huge percentage of it will go by without any accountability or repercussion whatsoever.
That's the piece, I think, for where I'm sitting as a layperson. It's, it can be daunting to think about the systemic change, but I do think that, to speak to your thought of looking at other examples in other industries or just other spheres, it's like there are things that seemed like they would never change, and then there's a moment, and it's not really a moment, it's a buildup and a buildup and a buildup, and then there's a moment publicly that the pendulum swings, and that all of a sudden there's awareness, there's accountability, and that accountability is what ultimately brings about change. So that's where we're going. We're going to be expounding. You've heard so far examples from Elisha's story and his experience, but the next season we're going to be expounding on these topics and still looking at the cracks in the system. We'll be bringing in other voices and other stories so that you can hear from others their experiences and their insights into this. And together we continue to steal Free State's phrase, we're still trying to find a better way. So if you haven't subscribed, please do so. If you haven't seen the rest, you can feel free to catch up. We'll be having some content in between seasons that you can catch, so stay subscribed and following along, and we'll see you back for season 2.